Hi, everybody. This is Erica Mello, and welcome to episode number 149 of Tough to Treat. And in this shorty episode, I really wanted to hone in on some advanced clinical reasoning with some of your toughest patients. And I talk about two patient cases of mine. We have not done a full episode on them yet, but we will at some point. And it challenges your clinical reasoning, because I call it advanced because it's really not about, well, did I miss something, right? Or, do I need to progress, an exercise, or do I need to do more release work? It's not about that. And, sometimes it is, but not with these patients that I'm going to be talking about. And when you have some of your tough patients and you've really done a lot and you know what their drivers are, and you've progressed through what you think is a really extensive program in there, not quite there. They're almost there. This is where you really hone your clinical reasoning skills, okay? And I talk a lot about what I did with these two patients, okay? And we hope you enjoy it, and Susan and I will be back next week with another episode. Hey, everybody. This is Erica Mello, and I just want to talk today about some advanced clinical reasoning skills that I think no matter what level of experience or how many years you've been in the clinic, I think we always need to go back and do chart reviews and really think about maybe, why our patients got better or why have they plateaued. So it's really about advanced clinical reasoning, excuse me, with very, very specific cases. I'll give you two cases of mine. These will be short and condensed. We have not done full episode podcasts on these two patients, so they will be condensed. I'll give you their quick history, but this really goes into, you're at a point with your patient, they're doing very high level work. Let's say they're somewhat active. They're doing high level work, but their dominant pattern keeps coming back for whatever reason. And it's usually, under a very high load or at a specific range in motion or a specific environment. Okay. And that's what challenges us sometimes. Right. And so in our last episode that Susan and I did, I believe it was 148, we talked about positioning patients to take out their dominant movement pattern, right? And that was a great episode if you did not listen to it. So you find out what their impairment is and really, use your creativity and exercise to put them in a position for success, so to speak. And so go back and listen to that episode. That was not a very long one, so it's definitely a doable in one sitting to listen to. So I will give you a one patient scenario. This is a rower. If you listen to my masterclass in 2022, before I launched my Decoding the Complex Patient course, I did a whole masterclass, about an hour and a half. And this particular patient was in there, okay? And he's a rower. I don't really treat him anymore. He's pretty much good to go, but he had a lot of left foot pain, okay? So that was his symptomatic area, occasional low back pain, but his left foot bothered him when he sat. And that was it. My left foot hurts, right? So long history of rowing, and I'm not going to get into the whole history, but multiple injuries to hamstrings, pelvis, and upper extremity. And it was really the foot. That was his issue. I can't sit because my foot hurts. And it was very specific to environment, mostly in the office, less so in other sitting environments, but still got it, but more so in the office. And his primary sort of driver was his foot, believe it or not. And his secondary was his thorax, or very strong, almost dual drivers or co-drivers, right, together. You would not think that his foot would be his driver, right? It certainly would, his pain generator, I believe was his lumbar spine. But at that point in his journey, I see patients who, had symptoms for years, and I'm usually one of a long line of therapists, right? So when they come to me, they've been to like 10 people, I'm exaggerating, but they've had their lumbar spine treated and not much better, right? And so he had your classic radiculopathy, basically foot drop at one point, and he sort of rallied with that and got better. But something was flaring up in his foot when he was sitting. So knowing that his primary driver was the foot and the secondary was the thorax, what I ended up, exercise wise, I geared exercise progression towards those two regions of the body. Okay, so this is about advanced clinical reasoning. Comes in to see me a while ago, probably about a month ago, right before the holidays, actually. And we're doing well, but he's still getting it in the office. And I was like, really? Because he had periods where he didn't feel it in the office, and that was a lot better. So everything was much better, but he was still getting it, and it was enough to sort of say, I probably need to go in for a checkup with me. And so he said to me, ironically, he's like, Erica, when I put a toe spacer in between my toes at work, I feel better. So what does that tell you? Right? So you figure somebody they're sitting in their office, they're sitting at a home office, they're sitting in a car, they're sitting at their dinner table. Sitting is sitting, right? Not really, right? So you think about those different environments, and driving wasn't as bad, but he definitely felt it. But different chairs, different environments, different shoes. No dress shoes, no work shoes driving or in the home office, only in the office, right? And a toe spacer made him feel better. I will tell you that in my treatment, I actually did tape his foot, his subtalar joint taping. Helped him tremendously. Why did it help? I will tell you, when he was standing, his bias was so far to the left because he was the left sweep on a boat. Okay. And so this little shorty is about, advanced clinical reasoning in the advanced time frame of a patient, not so much at the beginning. But bear in mind that he, was very, very left. Okay. When I saw him recently for the holidays, he was very, very much centered. Okay. So ultimately, you really want to think about, the center of mass. And if he had come in to see me and he was still far left, I'd be like, what's going on? But he wasn't. He was very centered. It made sense because he was feeling a lot better. But you still got that. And so I think at this point, in that clinical reasoning, what do you think's going on, right? When you change an environment, when you change input into the nervous system, like a prop, which Susan and I talked about in our last episode, 148, that changes input into the system. It does. And the body either I'm trying to think of a really good word to scientifically describe it. The body changes recruitment patterns. The nervous system changes. And it actually made his foot feel better. It did something, so input directly to the foot, which always helped. But he thought of a toe spacer, which was ingenious, right? Who would have thought of that? I certainly would not have, to be quite honest. I knew his foot was his driver, but I wouldn't have thought of putting a toe spacer in. So he did. And so that made him feel much better at home. I mean, in the office, excuse me. So the advanced clinical reasoning would say, why is that? It's changing the input into the system. So this is what I want you to think about. We can't change his environment because he needs to feel good in the office. But we can change his shoes while keeping environment the same. We can change environment while keeping the shoes the same. So I had him put different pairs of shoes on in the office, which he had tried and said he felt better with those. I also had him sit in the office and in barefoot and put his foot on a half foam roller. So it was in plantar flexion and then dorsiflexion. I said, continue to use the toe spacer. And then I said, you can also put like a foam pad, some something unbalanced under your feet. At the half foam roller was, I think, the best bet. And then I said, when you're at your home office, keep your shoes on, the shoes that bother you in the office. See out to really figure out if it's the shoes. And you would think that would be obvious, right? But it didn't come up at the beginning, right? And so you want to think about, how can I change the environment and change the input into his nervous system at this point in the program? It's not about adding that extra rep or doing another set of push-ups or doing another set of heel raises, right? It's not about that at this point. If you're confident in your clinical skills and you've seen objective changes and you're confident that you've got your drivers down, you need to think a little bit more advanced and think out of the box a bit more. How can I change the environment to suit, right? With him, It's, as I said, changing input into his foot by putting a toe spacer, by sitting up, by putting his feet on a half foam roller, taking his shoes off, putting different pairs of shoes on, right? Then putting his same shoes on in a different environment. So for example, at home, right? So there's many other ways you can do this, but I wanted to bring him up because it may be that this may be the last piece of the clinical puzzle, so to speak, that you need to get your patient home, so to speak. And think about, be open-minded. I mean, I just used the half foam roller because it was easy and it was his foot, right? And I've been to the office. Okay. So for those of you who are thinking of, you need to go to the office, I've been. Okay. And he was so far to the left when he sat as well. So that's all cleaned up. Okay. So you think about, how can I make the input into his nervous system different? Yes, it would be great if you could put in the half foam roller under the feet, but if you can't do that, think of something else. Don't just tell him to stand, right? Because standing always will make him feel better. He needs to sit and change his system up. You can have him put little Franklin orange balls underneath his sits bones, right? You can have him put his feet on, on a towel, anything to change the input. Okay. So I also actually gave him, just an FYI, for those of you who are thinking, I did give him the Recognize app for the foot to do, which, as you all know, is part of the graded motor imagery protocol. Okay. So I actually started there with the left-right discrimination. And I think that has been helpful as well. So this is just the first, this is the first patient. So my second example is about a patient who is not a rower. He was a tennis player, well, still is actually, but he was a tennis coach before he started more of an office job here in New York. And unlike my first example, he was still a little bit off center when you look at his center of mass over his base of support. He also tended to offload his right side. So when you saw him in standing, he was loading more of his left side. And significantly better, able to play tennis, continuous days, with pretty consistently, but he didn't have that endurance that we wanted to get. We wanted him to be able to play for multiple weeks at a time, right? And at this point, as a clinician, you need to make a decision. Are you confident that you have your primary driver, your primary region that is causing your patient's problems, right? So with this guy, he had a lot of right levator scap pain, and just sort of chronic, right? And his drivers, actually I say plural, was in his upper thorax. One of his main ones was in his upper thorax, and he had a very strong secondary issue in his right knee and foot. His right knee was in his history. Okay, so he'd been improving and able to play more, but there was something that we needed to do to really get him a little bit more endurance, more play. Like, for example, if he was a tennis player professionally, he needed to be able to get to the finals, so to speak, with endurance, right? So, and it wasn't really about his game per se. So my last patient, the rower, he was really quite centered when I saw him before the holidays. Really had improved quite a bit. And so we tried a different sort of reasoning process, right? So now with this guy, he's still, definitely improved, much more centered, but still a bit off. Yes, do I need to continue to treat his right knee and his right foot? Yes, right? So right levator scap pain, something is taking him to the left, whether it was an old knee injury or an old foot injury. My guess is this is old knee injury, and he just can't really get on that right side long enough to play and have some longevity. Okay, so the key here is, what type of program would you give him at this point? It's not about, training the foot or training the knee. He really needs to get centered, and you want to think about the activity he really needs to be able to do. And at this point, he's so much better. And, this was like the last, once again, the last piece of that clinical puzzle. And so you make a clinical assessment. Do I need to really sort of give him exercises geared to the foot and the knee? Is that going to get me the most bang for my buck? And I judge that to be a no, because he had made great gains, but he still was loading his left side significantly better, as I mentioned. But he needs to load his right side to give himself options for movement. We've all watched tennis at some point. It's a side to side movement. It's a weight shift, right? It's certainly 3D, if not, I don't know, 5D, right? Golf's a sport of weight shifts and rotation. Tennis is that as well, but it's a little bit different in the sense they need to move in and out of those positions a bit quicker. And so I felt that at that point, giving him like a knee program or a foot program, it wasn't going to take him far. And I could probably get him to do some work exercise wise that would incorporate those two regions of the body. So what I did was I felt that the main, I would say, dominant pattern at this point was just limb loading left, center of mass over base of support, further to the left, but now getting closer and closer to center, but not quite there, right? So what I need him to do is I need him to do some centering exercises. And those can be different for everybody. And a couple of the ones that I did for him was I had him stand with a sort of narrowish, not narrow, but hips width, or maybe wide, actually, wide base of support. I had him do bearing in mind he has a knee issue, right? Doing a small sort of side lunge to the right, and then getting himself back to center. So I need him to train center. So does she want to just sort of, while you're listening, stand up and just do a little bit of a step to the right with a little bit of a lunge. So you're way on your right leg. Then now I want you to get back to center. I need his brain to find center. And I did that as well to the left. Okay. Anything going side and then finding your center is very helpful. You'll find that the person will have a little bit more ease going to one side over the other. And it's ironic because when he went to his left, which is where he loads, in order to get himself back on his right, he literally went into a side bend on his right side. He could not translate the thorax over the pelvis at all. He went into right side bending and left thoracic translation, which was his non-optimal pattern, right? So that is key. Okay, so doing like knee extension, hamstring work, footwork definitely would not have centered him in that way. So you want to think about at this point in the program, it requires some advanced clinical reasoning. What do we need? What's going to take him home, right? So that is one centering exercise I did. I also had him do like a split squat, also bearing in mind the foot, right? So we have to make sure that we release enough layers in the knee and the foot that he could do these exercises, okay? However you release, right? And you want to think about, I would just throw that in as a side and make sure you release in all different positions. Knee flexion, knee extension, dorsiflexion, plantar flexion, prone, supine, long sit, sitting on the edge of the bed, right? So those are just as an aside. But so getting into a split squat position and just putting one foot on like a TheraBand or something, a line down the center, one foot on one side, the other foot on the other side, centering himself and going into a little split squat, keeping center. Another way to do this is in kneeling. I think Susan and I did a podcast on doing some work in kneeling a while ago. You're kneeling and you can actually lean against, have the front part of his chest against a bench. So his feet are actually taken out at this point, but he's still training center, right? So I had him do just a very easy TheraBand, just skull crusher, triceps, and stand in kneeling, right? Bearing in mind that he needs to stay centered, right? Even though he's not standing, his foot is still represented in his brain, okay? And so you can do anything in kneeling. You could do, as I said, skull crusher. You could do a little bit of shoulder flexion. I didn't want to put a heavy weight on him because he does have some anterior deltoid weakness and a significant overuse of levator scap in that position. So I did a very lightweight. The key at this point is not getting the deltoid stronger, it's getting him centered. So just remember that from your clinical reasoning. Okay, you can continue to do things in kneeling. You have a TheraBand behind him and have him do some protraction, eccentric retraction. Okay, in kneeling, once again, kneeling against something or putting something on the floor so he has a sense of center. You could also have him do squats, going, once again, having something on the floor and going down into a squat. So the two things I actually really gave him were the side lunges, getting sense of center, and then going into kneeling and doing some centering exercises in kneeling, maintaining his center. So I started off there. So just want to let give you all a food for thought on, if you've got people that are so much better, they're almost there, think about what is needed at this point to get them home? Do you still do more of the same? Okay, I hope this helps and helps you think out of the box a bit more. And once again, if you are not familiar with the podcast, and our website is toughtotreat.com, and it's searchable by keyword. If you have any questions or burning topics that you'd like to listen to, any podcast episode that we did with those keywords in will come up. And we'll see you on the next episode.